I think we can go ahead and get started. Hello and welcome everyone to Women's Health Tech Wednesdays. My name is Nina Joshi, and with us today we have Nora Dennis, who is the lead medical director at Blue Cross Blue Shield North Carolina. Before we jump in, wanted to give just a very quick background on myself. I work as a consultant and a design researcher at Kaiser Permanente's Health Innovation Shop, where I design and deploy digital health products and solutions. I have a couple of really quick announcements before we begin our conversation. The first is that there is a research study that is ongoing with Curio. So if you are interested and you are postpartum, please check out more information in the chat. We also have our Women's Health Tech Challenge in December, and registration information for the free event is also going to be in the chat. All right, great. And with that, I would like to bring out our guest, Nora. Welcome, and thank you so much for being here.
Absolutely. I'm so glad to be here today. Thank you.
Of course. Well, maybe we can kick things off by you sharing a little bit more about yourself and your background.
Sure, absolutely. So in my current role, I am the lead medical director for behavioral health at Blue Cross and Blue Shield of North Carolina, and also lead our healthcare equity team as well. When I came to this current role through my work as a psychiatrist and addiction medicine specialist, and also having a background that included a Master's of Science in Public Health, really focused on maternal and child health. I'm from North Carolina originally, and I feel that a lot of my focus on public health and healthcare equity really came from my own background. So I come from a diverse family. My mom is African American, my dad is white. They were married in North Carolina in 1969, and it was illegal at that time for them to get married, but they did so anyways. And I always just came from a family where, on the one side of my family, my grandfather was a plasterer with an 8th grade education. And on the other side, my grandfather was a professor of biochemistry who had gotten his PhD from University of Chicago and his postdoc at Cornell. And these two men were equally intelligent, and they had equal amounts to offer. And yet what the opportunities they had been so incredibly different. And the way that they saw themselves was different as well as a result.
Wow, I think that's so powerful. And I think it's so beautiful that you're able to take those experiences and now actually, be able to put them into work.
Yeah, it feels very fortunate. I feel really happy because I think that, at Blue Cross and Blue Shield of North Carolina, we define our purpose as really being about healthcare equity. And so we say, we won't stop until healthcare is better for all. And it just inspires me to be able to work for an organization that feels that's so central to our purpose and reason for being.
Absolutely. What are some of the things, or how would you define kind of your role as, the lead director for Blue Cross Blue Shield? What are some of the things that entail as part of that role?
So I feel like my role has sort of like different pieces. I think in my role as lead behavioral health medical director, I think almost constantly about access to behavioral health services for our members. And, in North Carolina, Blue Cross Blue Shield holds a lot of the market share in terms of commercial insurance and also in the Medicaid space. And so there's really an opportunity to really drive the market, I think, as well as we kind of think about what the community's needs are, then that sort of pushes things in one direction or pushes things in another direction. And so I look at the whole state, and I look at all of the areas where we have some areas that are really wealthy and well-resourced, and we have other areas that are among the poorest in the country. And in my mind, all of those members are equally deserving of access to healthcare services, and I work for them. So when you are in health insurance, when you're in a payer role, you have a fiduciary duty to the members. You need to make sure that they have access to services, and you need to be able to assure the quality of those services. And so that is really at the heart of what I see my job as, both on the behavioral health side and on the equity side, is can we do all of the things in our power to assure that our members have equal access to healthcare resources. And to me, that translates then also into equal access to health itself.
Absolutely. You touched on this a little bit, but would love to dig a little bit deeper. You were kind of talking about your role as a payer or provider. How can, payer insurance groups drive change to create positive impact? And what role do you think that they should carry when it comes to, making sure that access and the equity are taken into consideration and are not just that, but kind of the star when it comes to policies or, projects?
I'm so glad that you asked that. I'm going to back up a little bit and just talk about what I was doing before I came to Blue Cross. So before I came to Blue Cross, I was first behavioral health medical director and then chief medical officer at a very large nonprofit behavioral health services provider in North Carolina that oversaw behavioral health services for 30,000 North Carolinians. Most of them were either under a system that we call IPRS, which is basically publicly funded behavioral health services for folks who have no insurance, or they were in the Medicaid system. And what I encountered and what I really noticed was that everything that we did was often, or not everything, but so much that we did was shaped by what payers were asking us for, what payers wanted, that payers were really kind of driving, we might have been the motor for the ship, but payers were steering the ship in what direction we wanted to go in, and the ways in which that then trickled down to the way that services were provided. And so in the state of North Carolina, for the public behavioral health system, there's this huge emphasis on timeliness of access, and that people need to be sort of categorized as being urgent patients or emergent patients or routine patients, and then they need to get in a certain amount of time to see a provider based on that designation, although there isn't super clear sort of delineation of what constitutes each one of those. And so what that led to was a system that was really front loaded, where we're saying like, oh, we have to make sure to get these folks in time, but then we actually didn't have resources then dedicated to continuing their care and to making sure that they actually recovered from the issues that brought them in. And so then we would see, okay, well, we might have seen X number of thousands of patients, but only 60% of them, 50% of them actually got a second visit. So we were losing people, and I don't know that. So we were sort of put into like almost crisis mode all the time because of the expectation from the state, and because of this idea that like that access was the most important thing. And so when I saw this role at Blue Cross, I was like, whoa, like I could maybe try to create a system or create an incentive that would drive people to the outcomes that I know are really important based on my experience as a doctor trying to create positive outcomes for these people, and finding it really, really hard because it felt like the system was not designed with mindfulness of what those who are accessing it, what their actual lived experience was. And it was really just so fascinating and so exciting to consider that. And then once I came to Blue Cross, this work is long work. It's not quick. This takes time, and there's just so much thought, and it's a very deliberate process. But I think that we have so many levers at our disposal. Obviously, the most sort of blunt instrument is money, in terms of like, what do we pay for, what do we incentivize, and how do we communicate those expectations, and in an ideal world, I think we're able to create incentives or programs really in collaboration with providers, rather than there being this sort of hierarchical or dictatorial relationship. In behavioral health, that's a little bit harder just because of the fragmentation of the behavioral health market. So, if I'm in primary care, or I'm like directing things towards, surgery or something like that, then most of those services are provided by these huge health systems. And so then you can kind of change a standard through like a single contract that's going to then impact a really huge number of people. Whereas for behavioral health, we have a lot of little providers. And so that's another really interesting challenge as we try to drive change, is like, how do we do that at scale without alienating or leaving out all of the little guys?
Yeah, absolutely. You bring up behavioral health and kind of use that as an example, which I think is so powerful, because I think if anything, this past year or so with everything that's going on, I think has really just shined a light on an existing, healthcare crisis, I would say, when it just comes to access. What are some of the things that you think need to change to really be able to tackle healthcare? Or I guess I would say, what are some of the areas of opportunity that you see to kind of take the mental health sector that you were talking about that is so fragmented kind of to the next level?
There are many different opportunities. I think the one that is sort of the most in everyone's face and where there's been the most energy is, of course, around telehealth, because we've had these really dramatic changes and restrictions around originating site and around the site where telehealth is delivered, so folks can actually receive these services in their home. It seems almost as though these sort of changes in the law were designed for behavioral health. And so in 2020, at Blue Cross, we saw that 54% of our telehealth services were for behavioral health. So it was really clear that behavioral health kind of took the telehealth opportunity and ran with it. But I also feel compelled to remind people that, if I look at our state of North Carolina, there are huge areas of the state that don't have access to broadband. And so we can't sort of jump on the telehealth train and abandon all other approaches without really thinking about like what are we doing for all of these people in our state and nationally who are struggling with this last mile phenomenon. They don't have broadband, they don't have upload download speeds to actually allow telehealth. And so we can look at audio only interventions, which I think can be very, very effective. But then I think we also really have to look at integrated care and look at integrated care that's meaningful in terms of directing access to behavioral health services that is evidence-based, that is timely, and that is of high quality. And that is where our team is really seeing a critical part of the opportunity. So it's really like a both and situation where we need to be thinking about collaborative care model, particularly bringing high quality behavioral health services into primary care. We have a service that we offer for our providers called Quartet, which is fantastic, really empowering referral and close connection between primary care and behavioral health providers, and then also looking at all of these telehealth opportunities as well.
Yeah, absolutely. You touched on something which I think is so important about how this transition to telehealth and how things like, technology like your phone or your laptop, pre-pandemic were a nice to have, but now it's kind of your lifeline. That's how you've been able to access so much care. And you bring up a really good point of access about how some people may not have either access to the technology itself or to the broadband that's needed. So from your perspective, what do we do to ensure access to care and to really make sure that it is available for everyone?
Yeah, I think that is a critically important question. So as you sort of alluded to, we can't make it the case that broadband is required and that a smartphone or tablet plus internet connection is a priori assumed in order for folks to have access to care. I think we need to be really data driven in terms of understanding the proportion of the need that we have. Let me take a drink of water real quick.
Yeah.
I get so excited and then I just
start. No, I love
it. But so what proportion of the need can we address with telehealth? It's going to depend on what population we're looking at. So maybe that's going to be lower for our Medicare population, where folks are older, and higher for our commercial population, and maybe lower again for our Medicaid population. And then if we have that residual need that we can't address via telehealth, I think that's again where we need to start getting really granular and understanding, like, are there like from a geospatial perspective, are there nodes or areas where that need is more concentrated? Are there certain primary care providers who we could consider to be like a nexus for that need that might be able to really drive access? Are there other community centers or community institutions that could also be points of contact? So are we thinking of one of the things I think is it can be really problematic if we take this like telehealth road and we take this sort of app-based road, is that we always will then consider the unit of measure to be the individual, and individual characterized as consumer.
Right.
But we know from a whole body of research on health disparities,
Mhm.
that the minority of variation in health outcomes is actually determined by individual behaviors.
Mhm.
So is health then an individual attribute, or is it a community attribute? And if we're looking at how we intervene, do we look at that as like, I'm going to give you, Nina, the one person, this one thing, or do I look at it as the network and the place and the systems that you exist within, and trying to resource those or change processes so that by virtue of simply being in a certain space, you would have access.
Right.
Those, again, I don't think it's an either or. I think that
Yeah.
they're complementary approaches.
Yeah. Yeah, no, thank you for that breakdown. I think that that's really helpful to understand how, this all fits from like a personalized level, but also from a community level. Since I think, like, exactly to your point, both of those are equally as important. One of the things that you kind of were talking about, in your role as equity lead, we talk about some of the things that we can do, but I think there's also, an important opportunity is really just baking in these like equity into just processes. So what are some of the things that you're doing or that you're seeing when it comes to how can we just start to make sure that we are designing for equity, that we're designing for access, kind of before it even gets to that point of deployment?
Yeah, I think that's such a great question. And I want to come back to a point that was made actually in a conversation with Blue Cross and Blue Shield of Massachusetts, who, like, among the Blues plan, is definitely such an amazing leader in this space. And what they really talked about is that this space can't be a competitive space. This has to be a collaborative space. And I think that is such a shift from, I think, the mindset that we have, which is a mindset that, the best gains and the, sort of way that things are going to move fastest is if we're all competing with one another.
Yeah.
But when it comes to innovation around equity, that we really, I think, have a shared understanding that there needs to be collaboration and sharing in order for us to move as quickly as possible, and that moving as quickly as possible is most definitely an imperative. And so I think there are so many different levers that we have at our disposal that can drive this change. We have to start with the data and with the measurement. And so in the commercial space, we have quite a paucity of race, ethnicity, language data about our members that is gold standard, self-reported, is sort of configured in a consistent way to consistent standards. And so that is a real focus of work for our plan, and that's really for all of the Blue Cross Blue Shield plans. So we have Blue Cross Blue Shield Association that kind of leads initiatives. And so one of these initiatives around equity is really about data collection and figuring out how we get that data from our members. Because once we have that data from our members, then we can understand where the disparities are most pronounced and what intervention is going to look like. If we don't know the where, we don't know which of our HEDIS measures or other metrics are most impacted, how can we then take action to address those things?
Right.
Simultaneously, we don't want to let the perfect be the enemy of the good. And we know that in this country, because of the long and brutal history of residential segregation and systemic racism, redlining, et cetera, that we do have geographic correlates to race and ethnicity, and that it's reasonable from my perspective to use area deprivation index or social vulnerability index, correlate that with outcomes, look for gaps along those lines, and then also use that data to really drive planning around interventions. But I think that one of the ways that things are different in terms of the traditional approach that payers have had is that our approach has often been one of scale and one of looking at utilization history to sort of assign where we should focus our resources. Right. And so that's like, okay, well, and I'll just choose, like, I'm trying to think of something sort of random, like, in this certain area, people are utilizing the ER too much, and they're, so we're going to take everybody who's used the ER more than 3 times in the past year, and we're going to assign them all into like this population-based program. We need to make sure there's at least 10,000 people, and then we're going to do this care coordination or other intervention with them. And so I think the question that I have, or the challenge for us, which is very much nascent, is to say, okay, well, can we shift this thinking a little bit so that what we're actually going to look at is a gap in a specific metric, or we're going to even look at a gap in utilization. So when we look at North Carolina, we have one county that's wealthy where 18.6% of the kids have behavioral health diagnosis or have had a visit, and another one, which is one of the poorest counties in our state, with 6.8%. Do I truly believe that 3 times as many children in this rich community have behavioral health problems as in this community that is struggling with poverty, struggling with addiction, as rural? Heck no, I don't believe that for a minute. They're telling me, the data is telling me that there's tremendous unmet need because of underdiagnosis. And I might not see that cost today, but I'm going to see that cost later. And cost is a proxy for human suffering, because this cost is people using acute services, meaning they got super sick and now they have to go to the hospital. So you know, when we look at all of these sort of all of these different goals or these different indicators, they fit together. Equity totally fits with our efforts to address cost and to address quality. And in the ideal scenario, if we can really find the places where the need is most pronounced, we likely often will also find that costs are higher. And what's nice is it's higher for us, but it's also higher for the patients. It's higher for the members. We share in their healthcare costs, and those are the people who can least afford it, right?
Absolutely.
So it behooves us on every level to integrate this information into our approach, so that rather than, and I think that like these efforts are longitudinal, as we said before. So I'm definitely not like thinking that from the get-go everyone should have been thinking about health disparities at the point when they were organizing, you know, alternative payment models or accountable care organizations, but we have the power now. And I think that like my wish and my ask to the folks in tech who might be watching or listening is that attention be turned to finding ways to integrate data streams and focus efforts, rather than us having to like reinvent the wheel and build it from scratch. Because that's what's happening right now, is that there's like, okay, let me build it from scratch, let me build it from scratch. And I keep thinking like so much of this data is publicly available data, and like, you know, we can, I think in the spirit of collaboration, there's such an opportunity to you know, bring together the information and help us really target things in ways that are going to drive positive outcomes.
Absolutely. Yeah, data, I think I like how, you know, you really talked about the need for data and the need for like contextualizing the data. I think that is also so important. And, you know, on that note, kind of talking about, you know, areas of interest or of focus to really, you know, improve just the overall ecosystem of health. What are some other areas of healthcare that you see room for improvement, you know, from an access perspective, from an equity perspective? What are some other key features that you would like to see changed?
I think that sometimes, so part of my role is I often have folks come to me with an app or a solution, and you know, and so much of the time it really still is in this individual consumer paradigm and in a wellness paradigm. So it feels like it's made for people who are generally pretty darn healthy and like to make them healthier.
Right.
And so we have the challenges that we have in North Carolina. We have kids who will be in the ER for a week, for 2 weeks, because they can't find a bed for that child in the hospital. There's not like a central clearinghouse that shows bed availability, despite the fact that I would say hospital beds in many ways are a shared good, right? Like they're a shared resource, and we have a shortage of behavioral health beds, right? So I'm like, can someone please solve that problem? It doesn't seem like it should be that hard. We have challenges where people will come from the correctional system into the public behavioral health system, and there's not like, the communication is not what it should be. And you know, those folks are at such risk, and the people around them are at such risk. That transition is really, really hard. And like, we don't have the tech solutions to empower that communication and the sharing of records. Like I still have never seen behavioral health records from a correctional facility for a patient that I was taking care of in the community.
Yeah.
This happens all the time.
Mm-hmm.
Prison's traumatic, and people with behavioral health disorders are more likely to end up in jail. And yet that connection point hasn't been solved. It would save states so much money if we could figure that out. So we was just thinking about like, who is my audience and what problem am I trying to solve? And am I trying to solve a problem that's like a micro problem, or am I trying to solve a macro problem? And I really believe that you know, this generation of women in tech can solve macro problems.
Absolutely. Well, I know we're almost short for time, but really just wanted to ask you, you know, I think to that point of you know, what we all can do, what advice would you have for aspiring entrepreneurs or you know, folks that are really passionate about this space and want to make a difference?
I think that it's so important to be bold and to be passionate and not to limit yourself to what has been done before.
Mm-hmm. I love that. Change the paradigm.
Mm-hmm.
That's amazing. Well, that's incredible. Thank you so much, Nora, for such an enlightening conversation. I think, you know, I just feel like we covered so much, I think really, really important change that is a brewing. So really excited to see what you and your team accomplish, kind of really, you know, setting the stage for how can we really just start to think of equity not as, you know, a buzzword or a nice to have, but something that's truly critical to just kind of the care pathway. So really wanted to thank you again for this enlightening conversation.
For sure. Thank you.
All right, everyone. So in terms of upcoming events, please be sure to check out our next Women's Health Tech Wednesdays next week for another conversation with Chirpy Bird. We also have, in terms of other events, our Innovator Summit of this year from November 30th to December 2nd. All of the registration information is also available in the chat box. And for those that missed the earlier call out, we are still looking for participants for our Curio study. So if you are interested in participating, all that information is also in the chat. And our Women's Health Tech Challenge is this December. So please be sure to register for this free event if you are interested. Going to be really fun and exciting. And if I spoke too fast, all of the event information is available on our social media. So please make sure to stay in touch. Wanted to say thank you one last time to our guest, Nora, for an incredible conversation. Thank you so much, everyone, and hope you have a great rest of the day. And before I end, just wanted to also say thank you to our sponsors, Goodwin and With Them, for this amazing conversation. Thanks, everyone. Have a good rest of the day.